All right, folks, welcome back to the blood. We're going to talk about white blood cells in this section. So let's just get started here. There are five types of white blood cells, and those are neutrophils, eosinophils, basophils, monocytes, and lymphocytes. Okay, and not only are those are there five types of white blood cells, but these three are called granulocytes because they have granules, and these two are called agranulocytes. So we have the three granulocytes and the two agranulocytes. All of them combat infection, or could even attack cancerous cells or viral infected cells. So they all work together to keep us healthy. But they don't all attack the same types of infections. Some of them might respond more strongly to a bacterial infection, where others might respond more strongly to a parasite infection, where another one might respond more strongly to a viral infection, and so on and so forth. So it is important that we know what they do because the clinical picture that you're going to see when you get a CBC back, by the way, a CBC stands for a complete blood count. The doctor's gonna order complete blood counts all the time on your patients. And what you're gonna get back is, well, lots of things really, but one of the things you're gonna get back is what we call the differential. And the differential is how many of each of these different types of white blood cells are we looking at, and are they within the normal range? So, for example, eosinophils respond to parasitic infections. If you got a differential back that had a large amount of eosinophils, larger than normal, then you would start thinking that maybe the patient has a parasitic infection. So that's why it's important to know the clinical picture here. So what can these white blood cells do? Well, first of all, they can diapedese. Migrating out of the bloodstream is called diapedesis. It has another name. It's called extravasation. Extravasation. So diapedesis or extravasation is migrating out of the blood. Well, why would you want to migrate out of the blood? Because the infection might be in the connective tissue or the skin or something. So, what's the sense of the white blood cells staying in the bloodstream if your infection is in the skin? You need to crawl out of the blood and get into the skin and fight it. So, that's one thing they do is they can crawl out of the bloodstream. They crawl out of the bloodstream when there's a chemotactic substance around. What happens is when our tissue becomes infected with a bacterial, virus, etc., chemotactic agents are secreted by the infected cells. And these chemicals attract the white blood cells. So this is called positive chemotaxis because the white blood cells swim or crawl towards the infection to fight it off. Now, what do they do when they get there? Well, it depends on which cell. For example, lymphocytes act a little bit differently than, say, monocytes. Lymphocytes make antibodies and can directly attack, but they don't phagocytosize. Whereas monocytes are big phagocytic cells. Matter of fact, three of them are phagocytic cells. Neutrophils, eosinophils, and monocytes can phagocytosize. Basophils release chemicals that we'll talk about, and lymphocytes make antibodies and directly attack. So this is what our white blood cells do for us. And by the way, we don't do much of this in lab, and you probably won't do much as a nursing student, maybe. I'm not sure. I don't know if they do this. Now, medical technologists do this every day of their life. They do lots of they might do 30 of these a day, 30 manual differentials a day. This is a seg or a neutrophil. We call it segmented neutrophil because the nucleus is segmented, and because we call it a segmented neutrophil, medical technologists abbreviate it segs. This is an EO. It has that nice orange cytoplasm. I actually don't think it's that typical of an EO because the granules aren't as apparent as they usually are. But you can see it's an E. I can tell it's an EO, although if I saw another EO, I could tell you it was more characteristic of it. This is a basophil, has dark granules in its cytoplasm, very rare cell. Less than 1% of the white blood cells are basophils. This is a monocyte. This is the largest of the white blood cells. This crawls out of your bloodstream often. Matter of fact, monocytes are only transiently in the blood. They go out into the tissues and set up shop out there all the time. And this is a lymphocyte. A couple different types of lymphocytes, T's and B's. T's attack directly and B's make antibodies. So these are your white blood cells. And I don't remember if we do the histology of this in lab. You might have to memorize these in lab, but not for lecture. I mean, the how they look. You definitely have to memorize them for lecture, their names and what they do. But how they look on a peripheral smear, I don't believe we do that. This is giving you absolute counts. This is important, by the way. Here's an absolute count. All right, and that's per microliter. So neutrophils, there's 4,000 of these per microliter of blood. All right, I know it says 4,150. I'm rounding. And by the way, look at the range anyway. The range is 1,800 to 7,300. So there's 4,000 of these per microliter of blood. Well, there's only 5,000 white blood cells per microliter of blood. So that means that 80% of all your white blood cells are neutrophils, and actually it's close to what this range is. See, I'm not using the entire ranges, I'm just picking one number. So most of your white blood cells are segs, neutrophils. Eosinophils. The absolute count could be, like I say, 165 per microliter, and that is about 2 to 4%. The basophil, the absolute count is 44 per microliter, and that's less than 1%. So you can see here that these white blood cells have absolute counts. Now, is that important? It's very important. You have to compare these relative counts. Let me erase everything here so you know what I'm talking about. You have to compare these relative counts, like saying 70% segs, 4% EOs, 1% basos, to the absolute count, 4,165.44. Because what could happen is your white blood cell count could be normal. It could equal 5,000 per microliter. Okay, that's a normal white blood cell count. But your EOs could be sky high in percentage, and your segs be low in percentage. See, your segs are supposed to be 70%. What if your segs were 35%? You cut that in half. And your EOs were 39%. Well, that's abnormal, but your white blood count is normal. Exactly. You have to be able to see a difference in relative counts, percentages, and absolute counts, and see if there's an abnormality. Because just because the EOs went up doesn't mean that your white blood count went up, or it could be that your EOs went up and your white blood count went up. It doesn't have to change it could change the relative count, or it might not change the relative count. All right, neutrophils attack bacteria primarily. Eosinophils attack parasites primarily. There's overlap, by the way, but I'm just giving you the primarily. And these guys release histamine and are involved in allergic responses. They're involved in inflammation as well. So that's what the basophils do. All right, neutrophils. They have this thing called a respiratory burst. And what happens is, this is talking about the respiratory burst right here. The respiratory burst is when the lysosomes within inside the neutrophil go through a series of chemical reactions where they make hydrogen peroxide, they make superoxide radicals, they can even make bleach, believe it or not, hypochlorite. These lysosomes inside neutrophils can make bleach. That's and that's hypochlorite right here. And they use these chemicals to kill the bacteria. This is called a respiratory burst. Now, why am I telling you that? Because there's a disease called chronic granulomatous disease where the neutrophils and other white blood cells, granulomatous, can't do the respiratory burst. These people suffer from a lot of infectious diseases. By the way, the abbreviation for that disease is CGD, chronic granulomatous disease. The disease is horrible. The patient can die from infections that you and I would not think anything of. And why? Because their white blood cells can't fight off infection, because they can't do the respiratory bursts. All right, so that's a neutrophil for you. Eosinophils, they're parasites. Think parasites when you see eosinophils. All right. Basophils, they release histamine. They're involved in allergies and inflammation. By the way, eosinophils are involved in allergies too. So basophils, allergies and inflammation, histamine. But if you look back, does it say it? Yeah. Look, eosinophils are sensitive to allergens as well. They could degranulate with an allergen. But the big thing with EOs is I want you to think about is parasites, parasitic infections. Monocytes are very phagocytic, probably the best phagocytic white blood cells they are. They enter the tissues all the time and become macrophages. Matter of fact, they're only in the bloodstream transiently. Again, we have absolute counts per microliter, and we have relative counts percentages. And yeah, you have to know them. You have to know these absolute counts and relative counts. Now, you have to know the gist of it. Like, do I want you to say, okay, I have to know that it's 200 to 950? Oh, that's actually not how I would memorize it. First of all, I would remember that never let monkeys eat bananas is the relative abundance. Neutrophils, lymphocytes, monocytes, eosinophils, basophils. And then I would have an idea about how much of these exist. So you can say, and by the way, notice I'm using the top end of neutrophils and the bottom end of lymphs. You could, let me see, what's the lymphs? 20 to 40. You could actually do 30 with lymphs if you wanted. But if you do that, then that's 100%, and that doesn't add up to anything. So I'm going to keep it at 20. Just have an idea of what's going on here. So that's 70, that's 95. I'm at 95 already. So basophils are less than 1%. So I'll give this 3 to 4. Let's just give it 3. Or let's give it 3 to 4. That equals 100%. So you can see, it's not that hard if you just have a starting point. Like my starting point is I always know neutrophils are 70%. And then I can go down from there and figure things out. I know basophils are less than 1%. All right, so I kind of have to have an idea about where these guys fit to be able to fit in their percentages. All right. Monocytes, they leave the bloodstream, they diapedese or extravasate very easily, and they're macrophages in the tissues. So they do a lot of phagocytosis. Lymphocytes, this is going to be covered in chapter 22 in a far greater detail, but there's two flavors of lymphocytes. Well, there's actually three. There's 3 flavors of lymphocytes. There's T cells and B cells, and there's also these natural killer cells. They belong to different branches of the immune system. T cells have T cytotoxic cells, which kill directly. B cells make antibodies. So they don't kill directly, they make antibodies. And the antibodies don't even kill directly. They do something that we call activate complement, which kills directly. So that's what the lymphocytes do. And this is a collage showing you all your white blood cells. And yes, it's important to know their ranges for your job because you're going to be looking at complete blood counts all the time and analyzing them. Now, this is not as important. This is very important if you're going to be a medical technologist. It's not as important for a nurse or a PA. Now, if you're going to be a doctor and be a pathologist, this is your bread and butter. So this is the lineages of your blood cells. And how it works out is you have the stem cell in the bone marrow that can become any one of the blood cells. It's called a multipotential stem cell. And this multipotential stem cell will divide and partially differentiate into these pluripotential stem cells. Like this is still pluripotential because it could become a B cell or a T cell. So that's pluripotential still. And certainly this one's pluripotential because it could become a red cell or a platelet or some white cells. So pluripotential. And then what they do is they divide again and they completely differentiate, but they don't mature yet. So this is completely differentiated. That means this cell can only become a red blood cell, but it's not mature yet. So differentiation and maturation is different. This cell can only become a megakaryocyte. This is actually called a megakaryoblast. This cell is still only partially differentiated, because it has to differentiate some more into a myeloblast or a monoblast. Now they're completely differentiated. This myeloblast can only become a granulocyte. Now there actually are 3 granulocytes. And this monoblast can only become a monocyte. So from here on down, these circled areas on down, what they have to do now is mature. I better erase this circular area because that's not true for that. So differentiation and maturation are different. All right. And then when these go through the maturation process, this is the mature cell that they release to the circulating blood. All the rest of this stuff above this red line is occurring in the bone marrow. And they release the mature cell into the peripheral bloodstream. However, lab techs look at peripheral smears all the time, and if they see an immature cell in the bloodstream, they know it means something's wrong. A lot of times what's wrong when you see immature cells is cancer, leukemias. But that's not always what's wrong. It could be other bone marrow issues. So lab techs look at this and they look for bands and metamyelocytes and myelocytes and blasts. Now, I will tell you this, that if a medical technologist sees a blast cell, they have to get the pathologist to look, because they're so undifferentiated. Or I shouldn't even say it that way, because that actually might not be true. They're so immature that they're tough to see what they are. So we need a second set of eyes from a person who does this for a living, only does this for a living, and is an expert at it. So that's what we do. All right. So that's the lineages of blood cells. Now I know what you're going to say. Do I have to memorize these lineages? No. Please do not memorize the lineages here. If you're going to go, depending what field you're going to, you might have to memorize them, but RNs I don't believe have to. Notice something else before I go on. Erythropoietin, a hormone. See, erythropoietin comes up and tells these cells to mature into red blood cells. Granulocyte monocyte colony stimulating factor. That's a cytokine that goes up and tells this stem cell to differentiate and mature into what? The granulocytic lineages, these 3 cells, and the monocyte lineage, that cell. Granulocyte monocyte colony stimulating factor. So in other words, there's islands of tissues in your bone marrow that have these stem cells that hormones and cytokines can activate to make more cells, to make more red blood cells or white blood cells, etc. All right, so there you go for that. The last section will be clotting, I believe. So I'll see you in the next section.